All right, let's continue on. We have here the myogram. It's a chart of the timing and strength of a muscle's contraction. Gram meaning recording of, myo, muscle. Huh? Threshold is the minimum voltage that when you reach that voltage, you will generate an action potential in the muscle fiber, right? And when that happens, you will produce a contraction. So the threshold is the limit, huh? The turning point. Twitch is a quick cycle of contraction and relaxation when the stimulus or a threshold is. All right, good. Now, there is a latent period. A latent period is a period or delay between the stimulus and the contraction. In this latent period, this is the one where excitation, contraction happens. Okay, remember that it precedes the actual contraction. So this latent period is very important as well, huh? If this is prolonged or this is shortened, then it will spell a condition happening in the system. Contraction phase is when the muscle generates external tension and overcomes the load and causes movement, right? Especially when we go and discuss the um, contraction phase in the later topics. Relaxation phase is when the tension declines and calcium is reabsorbed, and then it goes down to its normal situation before the contraction. All right. So in a visual picture, this is your muscle tension on the y-axis, and this is time run in the x-axis. So when the stimulation is started, right, at this point you then initiate excitation phase, right, which then produces action potential, which then leads to the excitation contraction phase, at which point you have now the exposure to the G-actin sites, and then when the club heads engage, now you have contraction. And each time the club head gets more and more into the thin filaments, the more the contraction gets stronger. It will go to a point where you've reached your maximum contraction, huh? So all this time, contraction is happening, you got power stroke happening, and you'll have cross bridges being built, and then you have full contraction. Okay, and this can go on and on, right? It can go on and on, either stronger or maintained, depending on what the situation is. But once the event is done or the command is no longer there, then you will not have the nervous signal anymore. You will not have the acetylcholine reaching its receptor anymore. Acetylcholine will become disintegrated by its enzyme. Calcium is reabsorbed, and all this is happening as you're now going into the relaxation phase. Notice it's longer than contraction phase because this can be sudden depending on the need that the contraction is being awaited for. So relaxation phase happens, and slowly the club heads disengage from the active sites. The active sites are being covered by the tropomyosin, and you eventually end up with the thick filament sliding past the thin filament, and you're back to a viable new start. Okay, huh? So looking at this, it exemplified everything that we talked about: excitation, contraction, contraction phase, and relaxation phase. So very, very important and amazing. All these are important. Any changes to this can dictate some abnormalities or maybe some changes in the quality and configuration of the muscle mechanism. Contraction strength with subthreshold stimuli, there will not be contraction at all because you're below the threshold. At threshold intensity, twitch is produced. Even at the same voltage, different twitch stimuli or strength can happen. One, the muscle starting length influences greater tension. Fatigue is growing as you continually use the muscle. Warmer muscle enzymes work more quickly. Temperature increases the activity of the enzymes. Hydration is important. Remember, you have heat happening in this system. Increasing the frequency of stimulus increases the tension output. Muscles contract with variable strength for different tasks. You can be strong, you can be light, you can be controlled. Remember that. It always happens in our daily activities, ADL, activities of daily living. Higher voltage excites more nerve fibers, which makes sense. And the more motor units you include or contain, the more the power is, or the stronger. Weak stimulus recruits smaller units, while strong stimulus can attract and call in more larger units for more strength and power. As you see from here, the moment the stimulus has been started, you don't get all the contractions happening yet, right? But as the stimulus is increased, the nerve fibers also get excited, right? And actually, if this is the stimulus, right, and this is the proportion of nerve fibers excited, then you'll see a lot more parts of the nerve fiber increasing the stimulus until you reach the threshold. On the bottom part, you'll see the tension and the response of the muscle. Response is negligible in the first few times when the nerve has gained enough ground to hit the threshold or reach a threshold. That's when you see a beginning response from the muscle. And as the stimulus is continued, right, then you feel and see more contraction in the muscle. Now, as this is going on, right, the more stimulus you get, you will have a maximum contraction from the muscles. It will still be strong. The stimulus here will be added to the longevity of the contraction and will stay contracted all the way to the point where no contraction is needed anymore. Right? But we got to reach the threshold to begin a more legit contraction, if you would, and therefore make the work that we needed to do. Low frequency will produce identical twitches. The higher the frequency, it produces a temporal or wave summation. It can also ride on the next coming up wave. Only partial relaxation between stimuli rest resulting in fluttering results in incomplete tetanus. So in this picture, this is our usual low stimulus frequency. But if we have a continuous stimulus, the first stimulus goes up, and before it dies down, like this would happen here, another stimulus is initiated, so we get to begin at a little bit more higher place than when we started. And if that happens again, we are actually starting at a higher uh, start point. And eventually, you will reach a point where you either reach the threshold and you get more events happening, or you keep on increasing the uh, stimulus and it will give you a corresponding effect at the muscle strength. When you have complete tetanus is when you reach the maximum contraction capability of the muscle. And if you increase more stimulus, you will reach this capability faster and earlier. With sustained stimulus, you will have this contraction consistent and strong. It will stay. Will probably no longer go any shorter, but it will maintain its tension. All right. All right. Let's switch to another topic. This is isometric and isotonic muscle contraction. Isometric is when the muscle produces tension, but external resistance causes it to stay the same length. Right. This is also important in postural muscle function. So we have a balance of prime mover antagonist muscle in our body, so we actually stay in the same position. Isotonic, and remember in isometric, the the measurement or the length of the muscle does not change. It's isometric. In isotonic, the tone of the muscle does not change. And we'll explain that as we go along. Two other items before we go to the illustration is concentric contraction, when the muscle shortens as it maintains tension, and eccentric contraction, when you lengthen the muscle as you lower the weight. In essence, concentric contraction is your forward movement where the insertion approaches the origin. In a classical situation, you could also do the opposite, but the forward movement is a concentric contraction. In a classic example, it would be the insertion going towards the origin, the insertion part of the muscle, and then it goes back to the origin. And eccentric is when you go opposite from the origin down to the insertion. Here's to exemplify uh, isometric and isotonic. Picture a patient who lifted a resistance or weight. There's definitely some effort being exerted by the muscle because there is weight involved. But at this point, before she begins any movement and just holds a resistance on her hands, in her hands, she's already exerting effort, right? And the muscle is tense to a certain point. But the muscle length is not changing. She's not moving, so it's not changing. We call this condition isometric. It's contracting, but it doesn't change in length. So we call it isometric. Now, when she starts to lift the resistance, right, and it's going into a flexion movement, it is also going from insertion towards its origin. And so when you perform the movement, it will perform a concentric contraction, concentric from insertion to origin. At the same time, once you start moving, you will change its length, the muscle length. So it's no longer called an isometric condition, no longer. At this point, when you start moving it, right, but you maintain the strength to move it in the same timing and proportioned movement. Okay, no increase, no fast, no slow, just continuous, steady flexion. Then you are maintaining the tone of the muscle, right? Whatever it needs to slowly make that movement consistently, if you have to increase a little bit, if you have to maintain a certain tone, it could be a steady increase, right? Or it could be a tone that's maintained, all right? So if you don't let it go weak, otherwise it won't continue its travel. You don't get it too fast that it goes fast um, uh, than normal. You want to lift this in a regulated, right, concise manner. So when you do that, your tone this time is the same, isotonic. Isotonic. Okay, everybody get that? When this happens, also, you move from a potential to kinetic, right? Kinetic motion. The end point of this is when you reach the top. And reaching the top, okay, you will be at peak right there. You may stop momentarily, at which point, if you stop and there's no movement happening, you then acquire another isometric condition. Although this time it's a short muscle, not a long muscle. At full contraction at the peak, and if you hold it there, then you are in the isometric condition again. This time, fully contracted short muscle. At this point also, your isotonic disappears because you are uh, increasing you reach that point and you are trying to maintain that contraction. You may increase a little bit or decrease, you just want to maintain that length. You also reach the top, so your concentric contraction ends right there. The next movement is to slowly lower the resistance. And when you do that, you're actually going from your origin away from origin going to your insertion. And if you go from origin to insertion, you are producing an eccentric contraction. Still a contraction, take note, huh? Because you really are maintaining the precise, detailed movement of it, right? Same rate, so you're still contracting, right? You didn't just drop this off. You're still contracting, and at this time, you're trying to maintain that downward movement. You are now back in isotonic, maintaining the tone, and you are no longer isometric because this will slowly lengthen, huh? And now you are from potential, when you are at the peak, now into kinetic energy or kinetic motion now, until you reach the beginning point, the same as you were in this position. All right, so you see, a lot of things happen from isometric to isotonic to isometric, from potential to kinetic to potential, from potential again to kinetic to potential, and then from concentric contraction, concentric contraction to eccentric. Okay, huh? Again, when you lift the muscle up, you will, before lifting, you got isometric, and you are in um, potential. When you start lifting, you will be in isotonic, and you're going through kinetic motion. When you reach the peak, you then are in a tight, contracted form. Muscles are short, but they stay the same, so you're back in isometric, and you've just completed your concentric because it came from insertion towards its origin. Next thing is to release the weight, meaning to lower it down. So you go into isotonic again because you change your muscle length, and you go now from origin to insertion, and that is eccentric. And we go from potential to kinetic again until you reach the beginning point. You're back to potential, right? And you're back to isometric, right? Remember that, huh? Especially when we perform rehabilitative procedures, or when you want the patient to um, move their muscles or their extremities. Here's another picture of it visually in a graph. This is the length of the muscle, and this is the time, huh? So the beginning part, as far as the muscle length is concerned, holding the weight steady in the beginning at the bottom, if you would, they call it the bottom part, and then slowly lifting the resistance, therefore your muscle gets shorter, right? And look at that, it's getting shorter. This is the length or tension. For the length, this is getting shorter, okay? Right. And so this is your shorter, right, in length. But at the same time, we are, look at the red. The red is the tone of the muscle. We are maintaining the tone, right? And this is, so that's called the isotonic phase. It's getting shorter when we reach the peak. Then the length is at its shortest. Okay, and as far as the size is concerned, during the beginning, the size is pretty much the same as it is. But when you release you release the weight, this time the tension, which has increased, trying to maintain that length, will now try to be uh, static, or at least consistent in the tone and tension. I maintains a tension all over the whole concentric procedure. Eccentric, you will also release and make the length longer, right? Huh? See, the length will get longer. You're going back, so you see increasing length. But you are going back, still maintaining the tone, right? Isotonic, and going back eccentric, right? And then what would happen is you will have reached the bottom part where you maintain the length, but your tone is getting less stronger than when you started because you're now resting at the bottom again. Okay? Interesting, very interesting um, mechanism here. Now, muscles survive because of metabolism, huh? Muscles survive because of metabolism. And for that, we'll learn about some basic metabolic processes. Muscles contract depending on the ATP, and the ATP depends on oxygen availability and organic energy sources like glucose and fatty acid. We can produce ATP by anaerobic or aerobic mechanisms. Anaerobic fermentation will produce ATP, but to a minimal amount, right? It yields little ATP and will produce lactate, which needs to be taken care of by the liver. That's without air, anaerobic. If we have oxygen available, then it will produce a lot more ATP from about 2 to about 32, and you don't produce lactate. This will have to have a continuous supply of oxygen in order for it to happen. um, Here's another picture. Actually, let me go here first. In immediate energy, short intense exercise like a 100-meter dash, oxygen is briefly supplied. Myoglobin is used right away. Muscle needs ATP demand, so it'll borrow from other sources to make ATP. And those sources are the myokinase, creatine kinase. Huh? When this happens, what will be physically happening is, or rather metabolically happening is, we need to produce the ATP, right? In order to do that, we grab an adenine diphosphate, which means two. It'll be acted upon by an enzyme called myokinase. Adenine diphosphate will separate this into two, so the one monophosphate it will release, but it will grab one of the other phosphates, and then it will look for another ADP, a 2-phosphate. So when it has a 1-phosphate and it gets an 2-phosphate, it will then result in production of 3-phosphate or adenine triphosphate, and that's what we use for our energy, huh? So this myokine is very important, especially in the beginning when you don't have enough oxygen. And I'll show you that when we go back to the picture. Another mechanism is when you have creatine phosphate. We need to make ATP, right? So what we need to do is get the phosphate, creatine phosphate, get the phosphate, creatinine stays by itself, and then join or grab another adenine diphosphate. So we can join them together. They will result in ATP again, adenine triphosphate. Right? So in both ways, we are able to generate ATP even if we don't have enough oxygen. Those are the short-term ways to get energy and or ATP. Uh, you'll also have the glycogen lactate system, right? And when that is happening, you already have oxygen by that time. Then you can produce 20 to 30 to 40 seconds, uh, enough ATP for this much maximum activity. Long-term energy, about 40 seconds, the respiratory cardiovascular system have now doubled and increased in their activity. Like you're breathing deeply now, and you're also pushing or running a lot of blood through the system. Then you'll slowly be able to create the ATP needs that you have. Aerobic respiration produces 30 ATP versus 2 or 3 without oxygen. All right. So for 30 minutes energy, it's equal to about that same amount burning glucose and fatty acid. After 30 minutes, glucose may become less, right? Depletion of glucose causes fatty acid to become the more significant fuel. And maybe in exercise, that's when you start burning some fats, huh? Okay, now let's get back to that picture where you have an actual athlete going for the 100-meter dash, right? At the beginning, he's all tensed up a little bit, breathing a little bit heavier than normal, but not. But you don't see athletes at the beginning go at the beginning. You probably will look at him and say, "Wow, you're on something." You know, they may be tense, right? But maybe not heavily breathing at the beginning. So when the race starts, right, within a few seconds, 4 or 5 seconds, his muscles are full blast, but we know he doesn't have enough oxygen yet. So this is where the phosphagen system, creatine kinase, the enzymes that we talked about are kicking in to produce the ATP. We don't have enough oxygen yet. But after a few seconds, now that you have started the heart pumping faster, circulating the blood faster, going to the respiratory system, being replenished with oxygen. You're now also breathing more deeply, so you're now acquiring more oxygen, more ATP is now being produced, right? And even the oxygen we borrowed is now being slowly replenished, and this will go on and on, right? On and on, um, keeping to this system, producing a lot of ATP. When we get to the point when we finish the race, right? Uh, Finishing the race, our system is still on the go, Your breathing is still heavy. You probably are moving less, Maybe walking a little bit, but you're still breathing because number one, you set up that rhythm already. Number two, it's still paying oxygen debt. All right, the oxygen that you used throughout the system or throughout the procedure is now being replenished fast, right? Before we end up with some uh, breathing abnormalities. So that will go on, and eventually this will settle down, and the athlete is back to his normal respiratory rate and have more or less returned back his energy and have recovered from the race. Again, you don't see a person running, 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 and then when you cross the finish line, just return back to normal breathing. Da, 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 da. No, he will, even if he tries to hold it, trying to be looking like brave and all that and mighty, his physiologic body is still panting because it's paying back the oxygen that the muscle and the system is done. The heart is still pumping fast here. So the whole system is still going to run like that for a few more seconds, maybe a minute or so. Right? So all through this, you witness how we came from anaerobic to becoming aerobic and then settling down. We came from uh, being using enzymes in order to survive, and then finally recuperating or surviving through our own oxygen. Okay, very amazing and important. For long-term energy situations, like we said, we will shift into aerobic mode and then get more energy and ATP. Now that was a 100-meter dash. Another system will have to be devised or another pattern if this athlete was in a marathon. You can imagine a big difference. You don't push or shoot the muscle to the max. You more or less maintain and consistent with your speed and be sustainable all throughout. While the 100-meter dash, it's all cards are on the table. We need to win this race, and everything will be at full blast. Now, can muscles be always strong and not defective? Well, muscles also have fatigue, yeah? And muscle fatigue is when you have prolonged use of the muscle, and it will deplete. It will deplete the resources and end up either in pain a little bit or in weakness. In many cases, this system can also build up some resistance or endurance. In endurance, we are able to train ourselves to be at that certain level, sustaining ourselves, making ourselves continuously uh, adapting to the situation, and probably be at the very best. So endurance can also be seen, for example, in long-term activity like marathon running or biking a long range, right? Or swimming even, if it's a longer length. So both of which can be achieved. Fatigue can happen, depending on how much training was involved. The more training, the better the body will cope up. Probably less chances of fatigue happening right away, or to the degree of fatigue, just a little bit, but still can manage to go on. There's such a thing as EPOC, excess post-exercise oxygen consumption. So what it is the difference between the elevated rate of oxygen consumption following exercise and the usual resting rate. So this is you still panting and catching up with your breath until it goes down to the normal. We need this to replenish the ATP that we used up, right? And we need this to replace the oxygen reserves on the myoglobin, while you're still panting and breathing hard. And also to provide the oxygen to the liver that is trying to dispose of the lactate byproduct. The cells, right? The cells also are needed by the cells also need oxygen that at this time have increased metabolic rates. So EPOC can be 6 times the regular normal consumption and may last for a few minutes to maybe an hour. Right, let's go to the classic muscle fiber, right? There is a slow twitch, slow oxidative. These are the red muscle fibers. And then there's also the fast twitch, fast glycolytic muscle fibers. Intermediates also exist to a certain point. Every muscle contains mix of fibers, right? Some slow, some fast, some intermediate. Some individuals are genetically predestined to have probably a stronger muscle in quality, and maybe a longer muscle sometimes, depending on what the event that person is engaging in. Hopefully, will fit to how his strength is, or how he can generate that. Okay. Muscle strength also depends on your arrangement of the fascicle, the size of the active motor units, the training that you give this muscle also. Muscle strength depends on temporal summation. The greater the frequency, right away we reach the threshold and the stronger muscle will contract. It also depends on how long and how short you start the muscle with. And also, how long has this been running? What is the capability of the muscle to sustain energy until fatigue comes in? Again, this is more or less adaptable and can be designed or practiced to be resistant to fatigue to a certain point. Now, resistant training like weightlifting involving contracting the muscle against a load develops strength. A few minutes of resistance can develop a good strength because you have muscle cells that have increased in number, or rather increase in size rather. That's why it's going to hypertrophy. Muscle fibers synthesize more myofilaments and myofibrils at this time and grows thicker, right? Giving it your hypertrophy. Now, in endurance training, this is when you design again your muscles to be fatigue resistant, right? And probably be able to save some mitochondria, glycogen for longer use time. Skeletal strength is also increased. Red blood cell capability is increased, and the function of the respiratory and cardiovascular system, together with the nervous system, has been trained to work side by side. Okay. All right, All these are seen in our muscles, especially the little muscle that we have discussed. Now, going to the other types of muscle, like the cardiac muscle, most of them are pretty much similar in discussion. Just to make sure that you want to refer to the cardiac or to the smooth specifically. Cardiac and smooth muscles have properties that are the same. They are involuntary. They receive innervation from the autonomic nervous system, and they will do or contract independently, even if you're not thinking about it. So here's the cardiac muscle. You see the branch cardiac cells. You see the little snatches or them or breaks. Those are your intercalated disc. And then the nuclei of the disc that we described. Okay, that's how your cardiac muscle looks like. Now with cardiac muscle, this has a regular rate and rhythm because you have a pacemaker. It also works in sleep or wakefulness 24/7. And because of this, it has a lot of mitochondria that it's resistant to fatigue. Huh? Very important that it regulates this and stays consistent in order for the heart to be pumping for many, many years to come. But this cardiac muscle, just like the skeletal muscle, is striated, although shorter and thicker. The sarcoplasmic reticulum is less developed, but the T-tubules are bigger. Now, cardiomyocytes have electrical gap junctions that help it stimulate its area and its own neighbor. And if it's damaged or any part of the muscle is damaged, it'll turn into fibrosis, which will manifest in a weakness to blow out that amount of uh, strength that is needed from it. Right. It follows also uh, the wave that travels from the muscle all the way to the tip of the or the apex where it can contract the ventricles. Cardiac muscles follow autonomic nervous system mechanism, which will increase or decrease its rate and contraction. Right. For aerobic respiration, the cardiac muscle is rich in myoglobin and glycogen and big mitochondria, so it's resistant to fatigue. All right. And remember, it is striated, involuntary, and has its own pacemaker. The smooth muscle is the next and last type of muscle. It has no striations. That's why it looks smooth. Huh? Smooth muscle lack nerve supply other than the autonomic nerve fibers that stimulate them. They are capable of producing new smooth muscle, mitosis, and increasing the number, right? Hyperplasia. Injured smooth muscle regenerates well. And smooth muscle is lower than skeletal and cardiac, but it can maintain its long contraction for a good number of time. For example, in the eyes, you can be steadily dilated to a certain point or constricted to a certain point. Um, if, for example, you're in a room with uh, less light, then you will dilate a little bit longer. If you're in an area where there's too much light, then you will constrict a little bit longer as well. So it can be sustained with smooth muscles. Smooth muscles look like this. You have your autonomic nerve fibers, and then you have your single unit smooth muscles. You can see your nuclei. And then you will have the location of the smooth muscles. You can find this in the gastrointestinal tract, that's GI. And it could also be found inside blood vessels, right? So you can constrict or dilate the blood vessel. It's also found holding on to hair or piloerector muscles, and it can be combined. For example, in intestines, you can have inner circular or outer longitudinal muscle outlay, ICOL. I am cool, right? Oh, okay. So inner circular and then outer longitudinal, both in the same area. So what happens is, as you contract the inner circular, it's either pushing that specific spot, or it's trying to digest and push more chyme into the walls of the specific small intestine involved. Longitudinal will play with the peristaltic need to move the contents towards the anus, huh? Towards the rectum, and that's for your peristaltic. All right, this also tells us that the Z discs are absent, and instead we have dense bodies for the smooth muscle, and then we also use the thick filament in another method, and by way of this, we're able to produce the items that we desire. Here's a magnification of the smooth muscle. You see the longitudinal smooth muscle here. You see the transverse smooth muscle fiber on top with the smooth muscle fiber in between. Here's another picture of the smooth muscle. The fiber itself is highlighted here, and then nuclei right there. It's highlighted here as well. Multi-unit smooth muscle happens in big arteries and air passages, or even the piloerector and iris of the eye. Autonomic nervous system is a very big influence for the smooth muscle. In fact, it follows and abides by that. The types of smooth muscle is also a factor. You have single unit, which is most common, happening in blood vessels, the digestive, respiratory, all the way to reproductive tracts or mechanism. Single unit smooth muscle, we call this the inside muscle or the visceral, right? The visceral muscle. Now, the smooth muscle will also look like this, sort of tapered at both ends and a little bit chubby on the belly. We call this the multi-unit smooth muscle. Well, this one is the single unit smooth muscle, right? Smooth muscle over there. Okay. Now, smooth muscle is involuntary, may contract when there's a stimulus. The stimulus is one that we do not create by our own. It's an involuntary, the autonomic nervous system takes over that. Now, there'll be a sympathetic and parasympathetic to this. The parasympathetic is for feed or breed, and in feeding, the intestines are made out of smooth muscle, so they can contract without us having to think of contracting them. Imagine if you're writing or making a speech and you have to work your intestines to contract because you're supposed to do it manually. You can imagine how the situation is. It's trying to self contract. It just can't. We're like, okay, hold on, don't talk to me. I'm self contracting inside my intestines. There you go, one. There you go, two. That'd be crazy, right? So it's a good thing, and we're happy that autonomic nervous system takes control over that. Okay. The hormones also affect the contraction of smooth muscles. Carbon dioxide, oxygen, pH all affect the level of the smooth muscles, especially with the uterine. Is a big factor too. Warm temperature relaxes muscle in skin or blood vessels, while the cold tends to tighten them up. And if it's tightened, the pressure will have to be variable in order to be made. If it's tight, you have to release a little bit. If it's loose, you have to tighten up a little bit on the pressure. Stretch is also a stimulus. For example, the walls of the intestines, as you feel that with chyme, the moment it reaches a certain stretch, it will signal a spinal reflex, which then comes back and initiates the uh, defecating maneuver or system. Stretch, that's why stretch uh, is a very big stimulus for this. Orthorhythmicity happens when the single smooth muscle cells in the gastrointestinal tract depolarizes at certain intervals. In the smooth muscle, calcium binds to calmodulin instead of the troponin that we see in the thin filaments. And this is on the thick filament. Myosin ATPase hydrolyzes ATP, enabling power and recovery, just like in the skeletal muscles. Right? Force is transferred to the plasma membrane, and the entire cell can shorten. Instead of it holding to bones or attachments, this can run on itself. It puckers and twists like wringing out a wet towel, right? Like you see here from this relaxed position, it runs on itself and tighten on itself that it can reduce to this size. See, almost like a towel being wrung by itself. Remember that you have smooth muscles in the intestines, okay, in the bladder, in the urinary system. The uterus is also made up of smooth muscle. The muscle in the layers of the blood vessel that can contract, making it vasoconstricted, are also smooth muscle. Muscles in the control of the pupils are also smooth muscle. You have inner circular, you have muscles that are pulling the edges of the iris and therefore increasing the pupil size, or muscles around radially trying to tighten the opening of the pupils. All right, that's also smooth muscle. In fact, any place that's needed to be involuntarily controlled and a skeletal muscle is too big, you'll find smooth muscle. The latch bridge mechanism is resistant to fatigue. That's why you can see a lot of this smooth muscle maintain their strength, be able to contract for a longer period of time. Okay, smooth muscle also react to stretch, right? Like it's exemplified in the digestive system. It also can relax after the stretch and then be able to contract again. You can see that in the bladder as well. It will stretch. If it reaches a certain amount of stretch, it will then send a signal to the spine, send back a signal from the spine, and then make that bladder contract accordingly, huh? Smooth muscle also has plasticity, the ability to adjust the tension to the degree of stress, right? Like, for example, the bladder, right? It will hold on to that stretch and still be viable, but it can also, right, uh, trigger contraction when it's stretched to a certain point, and it will squeeze out, all right, the product, for example, the urine, and then it will try to maintain that as well, huh? Smooth muscle can be anywhere from half to twice its resting length and still contract with a good amount of strength. Well, number one, there's no Z disc, so thick filaments cannot butt against them and stop contraction. Thick and thin filament are not arranged like your sarcomere. They're arranged in a cross bridge form. And cross bridge are basically not the mechanism. They are more into side by side, like we saw, huh? Being rung like a towel. The thick filaments of smooth muscles have myosin heads all throughout their length, so cross bridges can also be formed. Now, there will be some conditions that will, let's go for the abnormalities, huh? Some conditions that can exist that are considered out of the norm, huh? If you have muscular dystrophy, right, this is a hereditary disease where the skeletal muscle weakens and may even degenerate, right? When it occurs, you will have fat and scar tissue, which will not work the same way as your regular muscles will be. And there's many types of dystrophies, huh? Overall, there's weakness, and that may be happening all throughout life. And so there'll be a lot of rehabilitation that will be met. At the same time, this could be either congenital or hereditary, huh? The dysfunction of the muscle. In Duchenne muscular dystrophy, which is sex-linked, is one of the most common, happen in the male, and a mutation in the gene for muscle protein dystrophin has occurred. And what will happen is this can be a weakness manifested all through the many years, probably, but not beyond 20. It's a hindrance to long-term life. Huh? It can affect the respiratory, the cardiac muscles as well. So a lot would depend on patient is maintained and the quality of muscle left. Now, in facioscapulohumeral musculodystrophy, this condition is dominant in trait and can affect the male or female. The facial and shoulder muscles uh, are affected more than the pelvic muscles. Huh? So weakness can also happen. The limb in the girdle can also be dysfunctional in its growth, and this can affect the shoulder, the arm, and the pelvic muscles as well. Going through the last few slides, I mentioned myasthenia gravis earlier. This is an autoimmune disease where the antibodies attack the actual receptors, right? Receptors and also the neuromuscular junction. When this happens, you destroy the receptors, and therefore the acetylcholine cannot make connection. You will not have the strength. You will not have the quality of muscle contraction. Now, the fibers can become less and less sensitive to acetylcholine. You will see some drooping eyelids because the muscles of the eye can be weak individually than the other muscles holding the eye in the right line of sight. This line of sight can change, be off axis because of one weakness of one muscle. You will then experience double vision. Swallowing can also be a difficult procedure, especially when they're weak to even push the food properly into the esophagus. Limbs can also be weak, From a strength of 5/5 could become 1/5, 2/5. Strabismus is inability to fixate on a point because some of the muscles, extraocular muscles of the eye, are not as strong. Myasthenia gravis is can be treated by inhibiting the breakdown of the enzyme, right? If we inhibit, or rather, if we hold the enzyme, therefore it's not breaking down acetylcholine, then we can make it to last longer and connect longer with its receptor. That's one treatment, We could also take care of the autoimmune dysfunction by applying immunosuppressive agents. This will suppress the production of antibodies that antibodies that destroy the receptors. You know that the antibodies populate in the thymus, and another extreme procedure is to remove the thymus and therefore lessen the overactive immune cells. Plasmapheresis is also a good procedure because we know the white blood cells, the antibodies, are in the plasma. So if we go through that and remove the harmful antibodies and return the plasma, you lessen the overactive immune cells, right? Here's a picture of myasthenia gravis, and see how even one side is left drooping, the other may be independent of what's happening on the other side, right? There you go. All right, that ends this chapter. And together with this are questions that I can throw in. I did some questions in between the chapters, so I'm going to go direct the question on the other items that we haven't discussed. Okay, my question goes to the to the ATP. If there is an anaerobic process, true or false, anaerobic fermentation produces the most ATP, right? True or false? It'll be false, Anaerobic will produce very minimal ATP. Oxygen is a big factor for more ATP to be produced, All right, number two, when you are lifting a resistance and you're going through that travel, you are in isometric condition. True or false? When you're lifting a resistance and you're going through the travel or the length of it, this is isometric. All right, the answer for that would be false. When you're going through the travel, lifting the weight, this is isotonic. Okay, isotonic. When you are releasing the weight, you're going from the origin and then trying to go towards the insertion. This is um, eccentric contraction. True or false? Eccentric contraction. It is actually true, When you're going from the origin to the insertion, it's eccentric. I try to do this true or false questions because the multiple choice can also be done this way. You can be asked, one of these statements is true, Or you can be asked, all of these statements are false except for. See? So we could also train with a true or false. Now, when the muscle is at the peak of contraction and not moving, it is in isometric condition. True or false? All right, that would be true. You are in isometric, huh? Isometric condition. Now, your choices are skeletal, smooth, and cardiac. Muscles that are used for the uterus. Is it skeletal, smooth, or cardiac? All right, those are smooth muscles, huh? Smooth muscles. True or false? Uh, Smooth muscles are affected by hormones. True or false? Smooth muscles are affected by hormones. It is true. Because, for example, oxytocin, which is a hormone, abbreviated as OT, huh, will affect the smooth muscles of the uterus to contract, and therefore have to contract, and by doing that, continue to complete the delivery of the fetus. Smooth muscle, cardiac, or skeletal, this muscle has intercalated disc. Okay, intercalated disc, you will say cardiac muscle. Smooth skeletal or cardiac. Cardiac muscles have intercalated disc. All right, which of the following, okay, true or false also? Calcium connects with tropomyosin and initiates contraction. Calcium connects with tropomyosin and initiates contraction. It would be false, huh? Because it connects with troponin, not tropomyosin. Right. Okay. Now, the question is, the globin heads are located on the thin filaments. The globin heads are located on the thin filaments. True or false? Okay. It is false. It's located on the thick filament, huh? Thick filament. Which is the thick filament, actin or myosin? All right, the thick filaments are myosin. Okay, myosin. Okay, uh, which one is the borders of the sarcomere? Is it the I band or the Z disc? Which one are the borders or the limits of the sarcomere? Is it the I band or the Z disc? All right, it would be the Z disc. It makes the sarcomere. Right. Striations is present in smooth muscles. True or false? Striation is present in smooth muscles. It will be false. Striations are not present in smooth muscle, only in cardiac and skeletal muscles. Okay. All right. Last question. True or false? The latent period involves relaxation phase. True or false? The latent period in a muscle twitch involves relaxation phase. It would be false. The latent period involves the excitation and excitation contraction phase. The relaxation phase is way by itself. See? Way by itself. All right? There you go. There's a lot of new ideas and new principles learned in this topic, the physiology of the muscles, huh? So, uh, very good for our occupational therapists, for our sports medicine, and also for our nursing on the broad side of it, because you will have your patients with these situations. RT will always be instrumental, especially if you have, in your case, if you're taking pictures, the muscles pose as a added density, so you will have to adjust with that system. At the same time, you could also use the myogram for this, huh? And therefore be able to record, or you can even use some contrast media to detect why a muscle has weak contraction, maybe weak perfusion. Okay, so everybody will benefit from this, right? Okay, we'll go from here. Now the next lecture will be on chapter 17, which is the beginning lecture of um, next week. All right. There's a good chance we might be able to pre-record that so it'll be available to you sooner, right? Now, at this point, Friday, just for reminders, your uh, practice test is out and available already. Your week lab test is also available. Your actual week 3 exam is also available. And if you submit your assignment this Friday, you get some extra credit or make up points, huh? Make sure to catch up on all requirements on this third week so that when you go on the fourth week, you can concentrate on the rest of the topics. We have the chapter 17, your endocrine system, your male and female reproductive system, and chapter 29, which is also almost an extension of that. All right. Thank you for listening. And if you have any questions, email or text me, and I'll respond to you as soon as possible. Huh? All right. Have a good night.